Welcome to the Human Momentum Podcast. My name is Erik Schabert. I'm a doctor of osteopathic medicine with 12 years of medical education and more than a decade of clinical experience in family and osteopathic manipulative medicine in my background. My goal for this podcast is to sort through and distill down the confusing and often contradictory health information presented on social media into a format that you can use to become a more informed consumer of healthcare and partner with a health practitioner near you in order to get you the best possible optimized health outcomes. I named this podcast Human Momentum because I see getting people accurate information as giving them the tools they need to build their own momentum going forward through life and allowing them to get the best possible health outcomes and happiness. If this is your first time watching and you haven't done so already, please do hit that subscribe button. It really helps me get this information out to more people. And if you find the content useful or interesting, a like also helps us with the YouTube algorithm. And if you think somebody in your life could benefit from the information I'm presenting here, please do share it with them. If you have any questions or thoughts on the content of this video, please do drop a line in the comments section. I love interacting with my audience, whether you agree with the information I'm presenting or not. And with all that said, let's get on with today's episode. Welcome to the latest edition of the Human Momentum Podcast. Today, I am going to try to respond to a set of comments I received on a previous video I posted concerning managing elevations in Lp(a), an important lipoprotein. What is a lipoprotein, you ask? Well, these are proteins produced primarily in the liver that the human body uses to transmit fats, particularly cholesterol, around the body. Most of you probably realize that fatty substances like lard, animal fat, oils don't dissolve well in water. And since our blood is primarily water, our body needs to produce these vehicles in order to be able to get cholesterol around the body to where we need it. There is a population of influencers and other people on social media who are very invested in diets like the carnivore diet that are high in meat and high in saturated fat. Well, these folks are aware that these diets tend to elevate lipoprotein levels, and they are convinced that these diets are generally healthy and therefore that these lipoprotein elevations are irrelevant to cardiovascular risk and irrelevant to health. I'm going to go out on a limb here and disagree with them. I think the body of research evidence that we have indicates to the contrary that elevations in things like lipoprotein(a), Lp(a), and ApoB are indeed causative of atherosclerosis, atherosclerotic related vascular disease, and major adverse cardiovascular events, MACE, like heart attacks and strokes. This is a complex topic that requires a degree of nuance. There aren't a lot of absolutes in it indicated by the evidence. And so I'm going to try and jump into it here and see if we can get to an understanding of it. So buckle up and let's see if we can tackle this together. Our first step in the analysis here will be to look at this 1998 French study, and you can see the abstract here. This study was a trigger for this video in many ways. There was a viewer who commented on one of my previous videos, the topic of which was causation of heart disease, and was looking at a good lay explanation of lipoproteins and how they work. And I will include a link to that video in the description of this one. But this study looks at evidence of what exactly allows people who live past the age of 100 to live that long. And they started looking at a lot of different genetic factors. And one unexpected result found in this study was that average Lp(a) levels of the 109 individuals over the age of 100 was significantly higher than that of the general population. We're talking about a mean level of 33 milligrams per deciliter in the centenarian population as compared to 22 milligrams per deciliter in the control population they looked at. This was unexpectedly high, but we need to put this into context before we can make a broad statement that this shows that elevations in Lp(a) don't increase atherosclerosis, heart disease, and major adverse cardiovascular events. When we look at LP little a, the first thing we need to understand is what is an elevated level? And according to the data we have, a level under 30 milligrams per deciliter constitutes no increased risk of heart disease. Whereas at a level of around 30, we begin to see mild elevations. In the low 30s, we're looking at about a 1.2 times risk in major adverse cardiovascular event risk. As the level goes up, that level of risk quickly elevates. At around 50, we're talking about a 2 to 2.8 times risk increase. And when we get all the way north of 100, we're talking about a risk increase of more than 6 times. So you can see quickly that as we go up and up and up, we see an increase in the rate of atherosclerosis progression and an increase in major adverse cardiovascular event risk. Looking at this population of centenarians, though, we see that the mean level was just 33 milligrams per deciliter. And when you look at the distribution of levels they found, there wasn't anyone with a level above 50 milligrams per deciliter. This certainly is not what you would expect to find if indeed LP little a had no relationship to major adverse cardiovascular event risk. All right. So let's move on to another study now that starts to show you why potentially we do see a little bit more LP little a in this population. So this next study is out of Italy, and you can see the abstract from that study here. The next question we have to address from that prior information is, was the French study looking at a population of outlier centenarians, or is that something we see in the majority of ethnic groups? The 1998 study did trigger a number of additional studies to be done in Asia and the United States and Europe. What we saw consistently time after time is that in centenarians, there was a modest elevation in LP little a concentrations. The remaining studies reinforced what we saw in France. They did not debunk it. And that led to this Italian study, which was beginning to try and look at exactly why we might be seeing this. And they started looking at what LP little a is actually doing. This particular study looked at animal models of animals that have very similar LP little a function to what we see in humans. And what they found was absolutely fascinating, that LP little a elevates the risk for cardiovascular events by 2 mechanisms. The first one is that it actually pushes the clotting factors up. It has what we call a pro-thrombic function. That is, it causes different protein factors and platelets to interact in such a way that clots are more likely to form. This is obviously not good if you have unstable cholesterol plaques in your arteries, because those plaques tend to rupture, and when they do, the body's reaction is to trigger a clotting cascade over those plaques in order to prevent further damage. But what ends up happening is they block the associated arteries. This is the cause of the majority of heart attacks and strokes in the world today. Now, what this study showed was that in addition to this pro-clotting function, P little a also triggers some pro-clotting cascades that are very detrimental to cancer. In this case, what we have long known about cancer is that it is dependent on a process called neovascularization, that is creating new blood vessels and new clusters of blood flow to an area in order to be able to grow and metastasize. And metastasize means go to other places in the body and aggressively invade other tissue. It needs this blood flow. And what LP little a does is, when it is at present in levels above 30 milligrams per deciliter, it starts to interfere with that process. And what we saw in this animal study is having LP little a levels in that range ends up squashing down the ability of cancer cells to grow and to metastasize. The hypothesis off of this is that in human beings, having high LP little a, while it is bad from a cardiovascular standpoint, is actually quite protective against cancer. So if you have a level that is in kind of that Goldilocks zone where you're not getting too much increase in major adverse cardiovascular events, you can survive the heart disease from the Lp little a, and at the same time, it protects you from cancer. So that some of these individuals with modest elevations in Lp little a actually survive longer than you would anticipate because of the protective function against cancer. It's fascinating research. All right. Then the next question is, how sure are we that we're seeing this adverse cardiovascular event risk? And that brings us to this next study we are going to cover. While we have known for some time about this pro-clotting mechanism that Lp little a has, and we have been attributing the major adverse cardiovascular event risk associated with Lp little a to that, there was some data that called into question whether that alone could account for the level of risk increase we've seen. And especially with very high levels of Lp little a, we are seeing individuals who on autopsy dying quite young have very advanced plaque progression in their arteries. We wanted to know if this was just due to Lp little a or if it's simply due to other concurrent risk factors, and Lp little a just causes clots to form more readily when there is advanced disease. Basically, we're asking if Lp little a is just the chicken, just the egg, or a little bit of both. This next study that you can see here, published in the Journal of the American Medical Association in 2024, sought to answer that specific question. And what the researchers did was they took individuals with levels above 50 milligrams per deciliter and followed them for up to 10 years, scanning them before and after for progression of atherosclerotic plaques. And what they found really did start to answer this question to an extent, because even when they took into account the average impact in plaque progression of things like ApoB, insulin resistance, elevated blood pressures, and the like, they saw that individuals who had these elevated Lp little a levels above 50 milligrams per deciliter had plaque progression that was significantly beyond that they could explain with other risk factors. So this really does give us some pretty solid evidence that elevated levels of Lp little a, when you get at least above that 50 milligram per deciliter benchmark, does start to push plaque progression forward at a more rapid pace. This, combined with that prothrombin activity, gives us a very good reason why so many individuals with Lp little a elevations, particularly those higher elevations, go on to have heart attacks and stroke. All right. And where that brings us is to this idea that Lp little a elevated above 50 milligrams per deciliter is most definitely harmful. But it also leaves us with the idea that having an Lp little a between 30 and 50 milligrams per deciliter might be a good thing. We have medications on the horizon that are potent at lowering Lp little a levels. And I think the question needs to be asked is, how good an idea are these medications? And if they are brought to market, how low do we want to bring Lp little a? Really crashing it down well below 30 milligrams per deciliter for individuals who don't have levels down there innately might actually be harmful, and we might be increasing cancer risk. So that is something to keep in mind. For now, it's not a big issue because none of our medications really push Lp little a levels down all that much. The PCSK9 inhibitor medications, such as Repatha, do lower Lp little a levels by as much as 20%. But a 20% reduction is unlikely to push levels down in the majority of individuals we would treat for cholesterol anyways, to a point where they could potentially be harmful. If you take somebody who has an Lp little a level of, say, 35 and reduce it to 28, you're probably not causing any kind of significant difference. For individuals who do have Lp little a levels that are above 50 milligrams per deciliter, and yes, this is something you definitely should get checked. There are a lot of physicians in the US who don't routinely check this on their patients, and yet they should. So if you are someone with a family history of heart disease particularly, but just who wants to know what their overall heart disease risk is, definitely get this checked. It only needs to be checked once. Lp little a is not impacted all that much by lifestyle. It really isn't impacted by most medications. So getting it checked once in life is sufficient to know what your associated risk is. If your level is high, what our evidence suggests is that you need to control all of the modifiable cardiovascular risk factors. If you can get your ApoB, your insulin resistance, and your blood pressure down to levels that are ideal and optimal, the risk for LP little a being elevated really gets mitigated. And individuals with high LP little a levels that very aggressively control all of their other cardiovascular risk factors can indeed live long, healthy lives. The question we need to answer next then is, what kind of diet is going to be conducive to controlling these risk factors? And it really comes down to fairly obvious stuff. You want to eat a diet that is high in whole foods, that limits saturated fat, contains a large amount of fiber, and a wide variety of foods overall. So we're talking about limiting red meat intake to 1 serving per week, limiting overall meat intake other than fish to 1 serving per day, and trying to get as much protein as you can from all sources while getting a lot of fiber and consuming foods that, instead of having saturated fats, are going to be high in poly and monounsaturated fats. What specifically does that mean, you ask? Well, it means eating heavy fish like salmon and ahi tuna and mahi mahi, and using those meats as much as possible. It means consuming leaner cuts of meat when you do have beef and when you have, things like chicken and pork, right? You want lean cuts. You also want whole grains, not processed grains and not processed sugars. You want to consume whole fruits and whole vegetables as often as you can. Get lots of legumes like beans, of all different types, lentil beans, kidney beans, black beans. Those are all wonderful. Consume a lot of fresh vegetables and consume tree nuts like walnuts and pecans and pistachios and almonds. Get sunflower seeds in. And the more you can slant your diet in this direction and eat these kinds of foods and avoid fruit juices and beverages with added sugars and artificial sweeteners. The sweeteners, probably much less so. I think the big harm there with artificial sweeteners is they can generate sweet cravings in a number of people, causing them to eat stuff that's high in sugar a little bit compulsively. Otherwise, we are just looking at eating a healthy whole food diet. The video that I referenced earlier that the commenter originally triggered me to go in this direction on, the link to it is in the description, and it also has information on a video from Nutrition Made Simple, an excellent channel that I highly recommend. And this information talked about diets that can reverse atherosclerotic plaque related disease in your arteries and generally lead to health. It's very much in tune with the diet I'm talking about here. In any case, this concludes my coverage of this interesting and complex topic. In any case, this concludes my coverage of this interesting and complex topic. If you have questions, please do feel free to fire away in the comments section. I love interacting with my audience, whether they are very much in tune with what I'm saying or they have very different ideas and want to get my clarifications on it or would like to point me in the direction of another video. I will also include links to all the studies presented in this video in the description. And I want to thank you so much for watching, and I'll see you in my next video.